Right. I'll just confirm a second.
Navneet ji?
Yeah, I was just checking my slides. Right.
Yes, sir. Please go ahead.
Mm. Am I audible?
Yes, sir. You're audible.
Right. Dr. Bhaskar has joined.
He's having some issue in logging in. I think he'll be in a minute. Welcome,
Right.
Dr. Nilesh. Dr. Rohit. We'll start once Dr. Mallabhaskar joined.
Yeah.
My apologies, some technical problem.
No issue, sir. No issue.
Yeah. I think we got 14 people. Good afternoon to all of you. Gagan, welcome to this NSI webinar.
Right.
Yeah.
It's such a pleasure to
Good afternoon.
be with the neurosurgeons, right?
Yeah. I can see Dr. George, Nilesh, and many friends.
Yes, Dr. George also joined. Yes.
Matthew.
Matthew is busy with some meeting. So,
And rest all our panelists, Dr. Anita has joined.
no, Dr. Anita not yet joined.
Okay.
So just inform her. We'll start because time is 4:01.
No. Before you start, just brief that message you sent to me. Who will do what? Just brief everybody so that it's clear. It's all clear. No, whatever you have sent message.
Yeah, we'll do that.
Yeah, no. Just to tell others that this is the flow.
Yes, sir. We three have to manage. So I've already sent the flow, no? So we'll manage. No problem.
Yeah. Okay.
Shall we start? It's 4:02.
16 people. This is yeah. Dr.
Walsh also joined. Welcome, Dr. Walsh.
You joined. Hi. Good morning. Too early for you.
Yeah, it's a little on the early side, but what the heck?
Yeah, good. Very nice to see you. Welcome to our online program, and we look forward to see you in India at some point.
I'd love to. Thanks.
Yeah, your sky is real or artificial?
My background is an artificial one that makes it look like I'm in my office when I'm actually not.
Okay. Good. I think the Kodisharan we can start, I think. Dr.
We'll start now.
Dr.
Yes,
Kodisharan.
I welcome you myself, Dr. Kodisharan, Chair of NSI Webinar Committee. And
please restart. I think there
audible?
was some technical glitch. Yeah.
I welcome you all on behalf of NSI and NSI Webinar Committee. So we are celebrating our 75th year celebration of Neurological Society of India. Today we have a joint webinar with Indian Epilepsy Society with the help of Professor Dr. Mallabhaskar Rao. Today we have a coordinator for this program, Dr. Rohit Balasubramaniam, upcoming epilepsy surgeon from Kovai Medical Center Hospital, Coimbatore, Tamil Nadu, India. I welcome Dr. Rohit to introduce about the webinar.
Good evening, one and all.
Dr. Rohit, please go ahead.
Yeah. Slides are visible?
Yes.
Good evening, one and all. I'm Dr. Rohit. I'm a neurosurgeon practicing in Coimbatore with special interest in epilepsy. Just a brief introduction. As all of us know, the Neurological Society of India was formed in 1951 by the four stalwarts, Dr. Chandy, Dr. Ramurthy, Dr. Narasimhan, and Baldev Singh. The purpose of the society was to provide a common platform for neurologists, neuroscientists, and neurosurgeons, aims to promote education and research and maintain high standards of practice in the field of neurosciences. The Indian Epilepsy Society is basically affiliated to the International League Against Epilepsy and was formed in 1997 in New Delhi. It aims to bring epilepsy out of the shadows, and it is dedicated to maintain high levels of standards in the treatment of epilepsy, promotes education amongst the practicing neurologists and neurosurgeons. Both of them have common roots. The NSI was the mother society from which many subspecialist groups emerged. In fact, the founders of NSI like Dr. Baldev Singh and Dr. Ramurthy were also instrumental in establishing early epilepsy care in India. Recognizing now epilepsy is one of the most four common causes of economical and personal losses of primary brain disorders. So this eventually led to the birth of Indian Epilepsy Association, that is for the layman, and Indian Epilepsy Society for professional medical advancement. The educational guidelines, the GEMIN, it actually helps the neurologists, neurosurgeons, and has laid down guidelines in the management of different forms of epilepsy. And many joint conferences have been held. Now, I invite Professor Mallabhaskar Rao sir to introduce the faculty.
So, good morning, good afternoon, and good evening to all of you. We are very thankful to the leaders of the Neurological Society of India for giving us opportunity to conduct this webinar. My name is Malla Bhaskarrao. I am professor of neurosurgery at MS Ramaya University Hospital. Prior to Ramaya, I worked at NIMHANS Bangalore as well as Sri Chitra Tirunal Institute in Thiruvananthapuram. I'll be speaking on the surgical aspects of malformations at a later point, and I'll be delighted to introduce all the three speakers of today's webinar. The first one is Professor Gagandeep Singh. He is professor and head of the Department of Neurology at Dayanand Medical College Hospital, Ludhiana, in the state of Punjab in India. He is an honorary professor, Department of Clinical and Experimental Epilepsy, Institute of Neurology at Queen Square, London. And I'm also delighted to mention that he is the chair of the Educational Council of the International League Against Epilepsy, first Indian to occupy such an eminent position. Dr. Singh, welcome to this webinar. The next speaker is Dr. Nilesh Kurwale. He is a very accomplished epilepsy surgeon. He is the director, neuroscience laboratory at the Dinanath Mangeshkar Hospital in Pune. He's a surgeon, and he's going to talk to you regarding imaging of epilepsy, of malformations. He's very passionate and then conducted several courses in India regarding the post processing of imaging of epilepsy. I'm sure you will find his presentation very useful. Now, to our international speaker, Dr. Christopher Walsh. Is a very eminent and accomplished epileptologist, professor of neurology at the Harvard Medical School, and is the chief of genetics and genomics and investigator at the Boston Children's Hospital, Boston, USA. In India, during the past 30 years, 15,000 epilepsy surgeries were performed. 80% of them are for hippocampal sclerosis and discrete glioneuronal tumors. So malformations form a lesser percentage, and unfortunately, the resected tissue is like a gold mine for research, and then it is highly underutilized in India. And we are hoping that Professor Walsh presentation will be educative and informative, and then hopefully this webinar and his presentation will help not only our service to people with progressive epilepsy and malformations, but also training our young neurology, neurosurgery, and allied colleagues, and also contribute to research in a significant way. Over to Dr. Gagandeep for the presentation. Dr. Kotishwaran?
Yes, sir.
Yeah.
So we'll proceed to the talk,
I
or
think-
we'll introduce our panelists also. Then we can proceed to the talk.
Please go ahead with panelists.
Yes,
then-
we have two panelists today. One is Dr. Anita Mahadevan, who is the professor of neuropathology from NIMHANS, and welcome you, ma'am. Second, Dr. G. Valinilam from Sri Chitra Institute of Neurosciences, professor of neurosurgery. We welcome Dr. George Valinilam. So we have speakers and panelists today. So we'll proceed to the first talk. So over to Dr. Gagandeep Singh.
Thank you, Dr. Bhaskar, and it's a great pleasure to be in the midst of neurosurgeons. Always, I feel neurosurgeons are the ones who actually we do a lot of discussion, we do a lot of thinking, but all the action is at your end. So I and some of my best friends are neurologists, including Dr. Bhaskar. So thank you. I think it's more out of our friendship that I'm here rather than expertise in. Of course, I practice epilepsy most of the time, and I do see a fair share of developmental malformations. And as I'm speaking, I'm going to start sharing my slides. So we do see, but then as Dr. Bhaskar mentioned, the proportion of malformations as the reason for surgery is rather limited, right? At least in our country, right? As most of these surgeries that are done are hippocampal sclerosis. And it's not for want of surgical expertise, but I think many of the uh, uh, surgeries for malformations of cortical development require a lot of inputs, a lot of time, a lot of resources, including financial resources. And that is probably the reason why we are going a little slow on surgeries for malformation, right? Now, I'm just to begin with and to give you a feeler about all of this. Oh my God, I'm so sorry. There is a problem. This video does not work for some reason. But okay, I'll tell you, this is a 3-month-old child, right? With spasms. And the important thing about the spasms is that they were really asymmetrical, right? Had epileptic spasms, and these spasms were really asymmetrical. And if you see the EEG also is asymmetrical with a right-sided predominance. So this is a question to everyone, and you can actually put it up in when I say asymmetrical spasms and the EEG is also asymmetrical. What is the likely etiology in a 3-month-old baby, right? Not on I'm basically an adult neurologist, but we sometimes, along with our pediatric neurologists, see pediatric epilepsy patients, and they are discussed quite often in our meetings. So what do you think is a likely cause? Is it a perinatal event, right hemimegalencephaly, SCN1A gain of function variant, or maybe the baby just had neonatal hypoglycemia, or it is this particular genetic disorder, right? Is it possible? I mean, people can put it in the chat. Sorry, I've gone to the next slide. What do you think, right? So whenever you have asymmetrical, and I think that is something which uh, Professor Walsh will emphasize when he talks about genetics, and when we have asymmetrical spasms, right? And spasms does not mean treatment with steroids, ACTH, vigabatrin. Spasms can also there are surgical treatments for spasm, and you start thinking in the lines of surgical treatment when the spasms are asymmetrical. That's the first clue from semiology, or first clue from the history, that suggests, okay, fine, yes, there is, and particularly when you have asymmetric spasms. Sorry about the background noise, but when you have asymmetric spasms, another thing that you should always think of is, are there underlying tumors, or are there underlying malformations which might be surgically resectable, and that can afford improvement in control of these spasms, and that can actually afford very good seizure control in some patients with epileptic spasms and hypsrhythmia. So that's what you can see the MRI, and this is why the spasms were asymmetric, and the EEG was also asymmetric, right hemimegalencephaly. So what are these malformations of cortical development, right? Um, uh, they actually constitute, and quite unlike the small number of patients who have actually eventually proceed to surgery, particularly in our country, nonetheless, they constitute something like 25 to 40% of all drug-resistant epilepsies, right? And we know that these are like small. We all have blemishes, right? So these are actually blemishes on the brain, right? Brain surface, brain within the brain, or at the deep down in the brain, but they're basically like blemishes, right? And everyone has blemishes. So the incidence of, or the prevalence of cortical developmental malformations, well, histologically defined, is probably much higher than what we think it is, right? Most of these patients present with epilepsy, but then there would be mm, children who present with developmental delay, children who present with autistic features. So these are the important features or clinical presentations of malformations of cortical development. But overwhelmingly, epilepsy, and particularly epilepsy that is resistant to anti-seizure medications, is the most characteristic feature of these malformations. The other thing that is very characteristic is the epilepsy is early in onset, right? Before 5 years of age, or around by 5 years of age, right? So when seizures occur very early in life and they are drug resistant, think of malformations, or suspect malformations of cortical development, right? By and large, I mean, there is this very elaborate classification which has been further refined over the years, first propounded in 2012. But to a neurologist who has some basic elementary understanding of brain embryology, I think you can actually classify, and this is a very logistic classification, is where there is abnormal cell proliferation and focal cortical dysplasia type 2, hemimegalencephaly, cortical tumors are good examples. And then there is neuronal migration from the ventricular surface to the surface of the brain, and lissencephaly, pachygyria, band heterotopia, periventricular nodular heterotopia. These are all good examples of abnormal neuronal migration. And lastly, once the neurons have migrated to the surface of the brain towards the cortex where they're supposed to be, there can be problems in the post-migrational organization. And that would be classically focal cortical dysplasia type 1, polymicrogyria, microdysgenesis, and schizencephaly. So that's broadly the classification of malformations of cortical development, right? But this is not EEG, this is not, but again, this is a question to if there are any of our younger colleagues here, students here. So I would ask you and to tell me what is the diagnosis or where is the abnormality, right? Anyone would like to put it in the chat box, right? Yes or no, right? So you can see this is the sulcus, right? And at the bottom of the sulcus, yes, I think one person has probably put it right. Um, Left frontal fed sag base, right? Uh, Right. So can you see this is the bottom of the sulcus dysplasia in the right frontal region, right? And correspondingly, you can see on the PET scan there is some hypometabolism in the same region, right? So my next question to you is if this is a bottom of sulcus dysplasia, what is that particular sign that is probably missing in this patient, right? Right. Right. Yeah. So the missing sign is the transmental sign, right? Excellent. I think someone has put it in the, I think that's absolutely right. And oops, right. Where is it gone? Right. Right. So that is a good example of a transmental sign, right? And I took this particular image from a review article published in Epilepsia just about last year. And I think it was a wonderful article, right? Because it gave a lot of schematics and which has actually really improved my understanding, and I would understanding of the development or the embryology of malformations of cortical development. And I would recommend that everyone should try to read this particular review article, which was published just last year, right? Uh, and there are these beautiful schematics which have been drawn out in this particular article, and this is trying to show what is the basis of the transmental sign. So you see these neurons from the periventricular zone, they start migrating to the superficial layers in the cortex, right? And when there is a problem in the migration and they remain like this, and there is this column, that is what leads on to the transmental sign, right? This is the paper, and I think this is a wonderful paper. Strongly recommend that people, students, everyone should read this paper to understand the embryology, right? Beautiful. It gives lovely diagrams, and it portrays what is the embryological abnormality in each of these conditions, right? Coming to focal cortical dysplasia, right? And you have, we know that there is a classification type 1, type 2, and type 3. And type 2 is also type 2A and type 2B, right? I'm not really going to speak on genetics because we have one of the best experts in the world who is going to be talking about the genetics of malformations of cortical development. Suffice it to say, this is a picture which I actually asked Google Gemini to make, right? So you have 6 layers in the cerebral cortex, right? So you can imagine a 6-layered cake here, right? Fine. Now, in type 1 focal cortical dysplasia, it's really, it does not show up on the MRI, but there is disorganization after the migrations, right? So the layers are not made out, but that does not show up on the MRI, and that would be a type 1 focal cortical dysplasia. However, when there is a problem with the migration or disorganized kind of thing, it would be a type 2A type of focal cortical dysplasia. And when this is associated with balloon cells, right? These huge cells, right? These are balloon cells. It's completely disorganized, then it becomes a type 2 focal cortical dysplasia, right? So remember a 6-layered cake and imagine a good 6-layered cake versus a disorganized 6-layered cake on your birthday. But then talking about semiology, here is this 30 years old lady who has had seizures since the age of 5 years, right? Now, her seizures used to begin in the right foot, right? She would have some kind of, when she actually began, right, when she was just 5 years of age, right? She would have some tonic posturing in the right foot, right leg, and she would be aware of this tonic movement. Sometimes there would be a pulling sensation in the right lower limb. And then she would actually zone out and would become unaware, right? Or would lose consciousness. I've written focal motor seizure with impaired awareness. This would, according to the current ILE classification, would be focal motor seizure with impaired consciousness, right? And then on occasion, it would evolve into a bilateral tonic-clonic seizure, right? But over time, this initial feature in the right foot would actually disappear, and sometimes she would have a typical seizure, which I would think as a temporal lobe seizure, in which she would become unresponsive and sometimes would have some rocky movements, some automatisms of the left upper limb. So it really became a temporal lobe seizure, right? And this is what the seizure actually looked like. I hope it works, right?
So the next step is to see neurosurgeon's topic.
Right. I'm actually talking to her and she develops the seizure. So you can see it involves the right side. There are some automatisms of the left hand, some rocking movements, very brief, is unresponsive during the seizure. Right. So clearly it is a left-sided seizure, and this is the onset of the seizure. And you can see the onset is in perhaps the left parasagittal region, right? It's on the left side, definitely, left hemisphere, but it is more prominent in the parasagittal region. These are double banana montage, longitudinal bipolar. First 4 are the left temporal, then right temporal, then left parasagittal, and then the right parasagittal. And this seems to start in the left parasagittal region, right? And the PET scan shows an area of hypometabolism involving the left parasagittal cortex here, but the MRI was completely normal. So this is where, and this is a functional MRI showing with foot tapping with the, this is for the left foot and this is for the right foot, where looks like that the with area for the right foot is slightly displaced anteriorly. So this is what you typically expect in type 1 focal cortical dysplasia, right? Another patient, and this was operated by Dr. Bhaskar when he was over to our institute for a demonstration workshop. And this is just way behind the motor cortex, and you can see this hyperintense lesion on these axial images, including flare. And when we did electrocorticography on this patient, we got these typical findings, right? And if I ask you, what are these typical, these repetitive spikes like this? These are the electrographic signature. This is another one where you have these repetitive spikes. And whenever you get these repetitive spikes, you can get them on surface EEG also, but not that commonly, but more common on intracranial EEG. And once you get them, that is a signature of a focal cortical dysplasia. So, ladies and gentlemen, just to summarize, MRI is the key in diagnosing malformations of the cortical development. They typically present with focal epilepsy, although it is well known that many focal cortical dysplasias can present with epileptic spasms and apparently generalized onset catastrophic epilepsy. But the other characteristic feature is the epilepsy is very early in onset. EEG will show evidence of focal epilepsy, but then if you are having spasms, there can be hypsrhythmia in a kid. If there is one signature of focal cortical dysplasia, it is these kind of repetitive spikes that I showed. That is the key, is a key finding, and that should always raise suspicion of focal cortical dysplasia. So I would stop here. This is what I can share about the semiology, clinical presentations, when to suspect, and what are the EEG features in people with malformations of cortical development, with particular emphasis on focal cortical dysplasia. Many thanks. Right.
Thank you. Thank you. Very interesting semiology and EEG. Over to Dr. Nilesh. Please unmute and then start your presentation. Thank you.
Yes. Good evening. Am I audible?
Yes.
Okay. Sharing the presentation. Are my slides visible, sir?
Yes. Yes.
Yes, yes, please go on.
Yeah. Thank you very much for the kind introduction and the opportunity to speak here. I will be talking on imaging features of cortical malformations and few representative cases. So we will have this talk in the form of, we have one data driven experience. I want people to understand about how MRI is to be interpreted and when is to be interpreted. So we did one experiment, and then how epilepsy imaging should be conducted, what are the prerequisites, how to read scans, how to optimize images, and few examples. This is how the talk will progress. So this is the imaging talk, and I am a practicing neurosurgeon. So I'm not a smart radiologist. This is my disclaimer. I'm a workaround neurosurgeon, and this forum is mainly for neurosurgeons, so they know what it is. And another is, I'm not published in radiology, and we have two phenomenal radiologists working closely with us, and they are in Dr. Anirudh works in our center and Dr. Yogeshwari works in the other center, but both of them are closely associated with the program. So with this, let's go to the fun experiment. We collected the data of all radiology reports of MRI and PET scan reports. They are reported scans of the patient who underwent surgery for focal cortical dysplasias and biopsy proven and seizure outcomes. We have the seizure outcomes. And we match them, these reports, with our multidisciplinary team meeting impressions based on semiology, video EEG, post-processing, and these isolated reports of MRI and PET. And this is a multidisciplinary meetings, impressions of the same radiology scans. And we classified these reports as positive when the radiology report actually matches with what we are trying to remove. Negative when it is complete, when the scan they could not find anything. And discordant means they reported something else and we operated upon something else. And we matched them with the histopathology reports as well. An interesting finding is only out of 120 patients, only 49% patients of 49% MRI reports were positive, 24% were negative, and 27% are discordant, means they reported somewhere else. So idea is, and in PET scan, 48% were positive, only 8% is negative, and 44% is discordant, means they reported something different than what we actually removed. Now, how to interpret this data? Whenever MRI report is reported in isolation, one more disclaimer here is the radiologist is working with us for last 10 years in a epilepsy surgical program. The MRI imaging is optimized. So despite these two facts, I mean, he's a good radiologist, good neuroradiologist, experienced radiologist in epilepsy surgery program. Despite this fact, when MRI reports are reported in isolation, the chances of them being correctly matching to what exactly you did for surgery is only 49%, 50%. And this discordance probably is because of they are associated with the surgical program, and they have some positive bias towards reporting more and more subtle lesions. Otherwise, in non-associated program, it might be just negative. So, but still, idea is only 50% MRI reported seen in isolation are positive, only 50%. So interpretation is, even if MRI report is negative for a dysplasia reported by whomsoever, how many, I mean, experienced radiologist also, I will state that probably this finding state that the MRI should be seen in association with or with video EEG, semiology, electrophysiological data, and post-processing. And another thing with the PET scan is positive PET scan is 48%, negative is 8%. PET is very highly, very unlikely to be reported as a negative in a case of suspected epilepsy. But it is very likely that it will be discordant. So ultimately, you cannot rely on these 50% of the cases. And when the chances of being false is 50%, other 50% just doesn't make any sense. Whom to rely is a question. So idea is, the most important thing is reports from MRI in isolation should not be reported in isolation or should not be interpreted in isolation. Negative MRI does not rule out epilepsy surgery. PET is highly non-specific investigation likely to be misled. A thorough workup is a must for epilepsy surgery, and referral to a program than OPD workup is more productive than anything else. So with this, why it is so? Because good clinical history, EEG finding, and a epilepsy etiological phenotype is a must before looking to MRI, because that is what your half the MRI findings reveal themselves. Expected radiology finding in this particular phenotype should be actually anticipated before even looking at the MRI. Good quality imaging is must, and we will look into it what exactly is a good quality imaging. And good quality viewer also is important, because I have seen many people have a habit of looking MRI on films or in a common viewer which does not have all the attributes or all the qualities of a good viewer required for epilepsy surgical imaging. So what are the sequences, what are the slices, what are the coverage and quality? We will talk about it. So this is a very good paper. It's published in Epilepsia. So these are the 4 sequence, and so 3D flare, 3D T1 for anatomical, this SWI for calcifications or hemorrhagic products, and T2 coronal for hippocampal abnormalities. With these 4 sequences, you can pick up more than 99% of the pathologies in entire epilepsy surgical phenotype, surgical workup. So if you ask me which are the sequences we do, it is 3D-T1, 3D-T1. So basically, it's a harness protocol. Now they are calling it as a harness protocol. But so it is published 1 mm, 256 by 256 matrix, no gap. Same is 3D flare. Same is coronal T2, where the acquisition should start from the frontal pole and end at the occipital pole, and not only the radial, not only the hippocampal. And the coronal T2 should be acquired perpendicular to the image to the line of hippocampus. So these are general protocol. Everybody knows it. Most of the radiology centers are still, I mean, even now they are doing it, but still they are missing majority of the dysplasias. And the reason is coil strength. We will come to that, but the coil strength. The other sequences that they might use is diffusion. This is generally for acute surgical work, acute epilepsy workup. Generally not used in a epilepsy surgical workup. Arterial spin labeling technique is recently introduced, and they're calling it as a poor man's PET, but it has many other flaws, and the resolution is more or less like a lobar or multigyral type. So PET has a much finer resolution. Inversion recovery and relaxometry are again optional sequences if you wish to do, but these 4 sequences will pick up more than 99%. Strength 1.5 Tesla versus 3 Tesla has already been now we have demonstrated that. I mean, many papers have demonstrated 3 Tesla is the choice. 2D versus 3D acquisition, it is optional, but still 3D is better because you can reslice the images and you can use it better for picking up subtle lesions using the imaging viewers. Extent we have already discussed. Coils 16 versus 32 versus 64. So the idea here is, even I have seen 3 Tesla MRIs with the 8 channel coil. It will not create a good imaging compared to 16 versus 32 versus ideal coil. Ideal or optimal, I would say, is a 32 channel coil. 64 is the best. Most of the centers currently have is 16. So as a neurosurgeons, we should inquire what is the coil strength. And I mean, Tesla, we all know, but coil strength generally we are not aware about. Now coming to the post processing, so MRI PET fusion is important because PET is very highly specific. If you know the MRI lesion, it's very highly. If you co-register MRI and PET, I don't have exact data, but most of the time it is positive. Although PET shows little more than what is MR abnormality, but still PET guides you for a resection and a craniotomy mapping. Voxel-based morphometry is a tool, and recently there are many efforts which are being done to automate VBM findings to pick up dysplasias, automated detection of dysplasias. PASCOM, SysCom are the newer tools developed in a software world to kind of pick up to fuse MRI and PET or a SPECT on a MRI and to find out those subtraction images. MAP18 is a program. It is reported again in the field of VBM, which is picking up and it improves the detection yield in subtle dysplasias. And there is another program which is MELD program, which is free fall, or any all of us can actually contribute to that program. So these are the type of post processing recently available. With this, let's go to the some couple of examples. What you can't see. See, majority of the time, the dysplasias or gyral dysplasias which are easily visible, they are glaring anyway, and most of the time they are reported. But whenever they are not reported, so there are 2 things which are missing most of the time. First thing is whether we are actually actually looking at a dysplasia phenotype. I mean, the clinical story looks like a dysplasia, and we are not finding a dysplasia. That is one thing. So I mean, many of the time, the story may not be of the dysplasia, and we are looking for dysplasia in a completely different phenotype. You're not likely to find it. The second thing is a dysplasia story, very critical, clinically dysplasia story, but you're not finding anything on the scan. And then most likely these are type 2A dysplasias, sitting at the bottom of the sulcus. So we as a imaging or a neurosurgeon should be looking at the bottom of all the relevant sulci and not at the crowns of the sulci. So that is the most important. Whenever you can't see things easily, check whether it is a definitely dysplasia phenotype. If it is a definitely dysplasia phenotype, clinically or electrophysiologically, then look at the bottoms of the sulci, not at the crowns. So this is a focal cortical dysplasia here. Now, what contributes this? We know that there is a cortical gray, and it has already been mentioned by Dr. Gagandeep sir that how the blurring happens. But this is a very simple example. This cortex is oriented in six-layered cortex. So look at it as a military parade and people watching it. So military parade people are actually very tightly organized cluster, while people watching are very haphazard. So this is a very good imaging. This is good shade versus this is a blurred shade. So that is where whenever the neurons actually are disoriented, you will find this blurred shade of the cortex. And if you kind of understand this, then most of the time you can have many other surrogate marker for the same finding. So in this, the thickness is increased, the shades are blurred. Here you can see a very nice orientation and organization of the people there. So this exactly happens on MRI also. Now look at now I will go with a few explanatory cases briefly. This is a classical MTS case, mesial temporal sclerosis case. Here, this is the temporal pole is sclerotic. They are called as anterior temporal sclerosis, recently introduced term used by many radiologists. So it is sclerosed. I mean, the temporal pole is small, atrophic in nature with a dirty white matter associated with the MTS. This is one finding. Now, second finding, look at this part here. So there is no MTS. There is no sclerosed hippocampus, but the white matter of the pole is dirty and cortex is clean, although. So there is a clean cortex, no cortical abnormality, but only white matter abnormality. So is it a sclerosed temporal pole? No, because temporal pole will be atrophic in nature. So what is this? So this is a new term, a recently introduced term called as MOGE. So oligodendral hyperplasia associated with epilepsy, mild cortical malformation. So this is a MOGE. So whenever you see a dirty white matter and a full volume pathology, meaning it's not atrophic, but white matter is dirty, and there is no clean cortical malformation or clean cortical abnormalities, then likely that this might be a MOGE. And third one is this. It is a clean cortical abnormalities. So it's a focal cortical dysplasia. So in temporal lobe, you can get similar features in all these three, but there is a subtle differences, and you can actually have a pre-surgical diagnosis even before going for a surgical biopsy. I mean, before histology. Now, this is very subtle finding. If you look at these two scans, the white matter on the left temporal lobe is bright white. It's bright white compared to the white matter in the right temporal pole. And right temporal pole appears fuller, meaning the cortical margins between, I mean, the gray-white differentiation is maintained but not maintained. It's very subtle finding. So this is again a minimal cortical malformation. Here it is crisp, here it is not crisp. And the extent is almost till the temporo-occipital junction. So generally this is very commonly missed, but if you have a suspicion, you can actually find it. This is a very classical focal cortical dysplasia, which have a blurred cortical margins, thickened cortex here, and gray-white differentiation is lost compared to this sharp gray-white differentiation seen here. So this is a very classical diagnosis picked up most of the time by radiologists. But the other first 3-4 categories, they're very difficult to pick up. But if you have that suspicion, you will find it. Now looking at this scan, looks like a focal cortical dysplasia. It's a thickened cortex. But what is abnormal? This is not a focal cortical dysplasia. This is simply a voluming or partialing artifact, because look at the gray-white interface. It's very sharp here. And when you look at the slicing of the brain in a three sequences, you can easily pick up that this MRI, this volume is sliced like this. That's why this thickening is apparent here. So in such cases, you have to slice this MRI perpendicular to this sulcus orientation to get the best view of your depth of the sulcus, and then only comment about the blurring. Otherwise, most of these F2 sulcus depth, they are generally parallel to the slicing plane, and you will find this kind of artifacts, and you might label this as a focal cortical dysplasia. Now, this is one more interesting finding here, as Dr. Gagandeep sir mentioned about transmantle sign. So here there is a thickened cortex. There is thickened cortex, but there is no transmantle. This is not transmantle. There is thickened cortex, but there is no transmantle. On the contrary, there is one more layer of cortical intensity is seen, and this comes as a focal neuronal lipofuscinosis, and these findings are now described as a radiology of focal neuronal lipofuscinosis. So this is double kind of focal double cortex, uh, but the histopathology is focal neuronal lipofuscinosis. Now, at times you find these focal cortical dysplasias as a blurred cortex compared to the other side. What we miss in such cases is the extent. If we keep on the top, so look at the white matter here and look at the white matter here. So this white matter is dirty white matter compared to this. So white matter, only having a look at white matter is very essential to understand the extent of focal cortical dysplasia, not just the focal blurring and the cortical abnormalities. Because if we miss this, then these patients would end up in a bad surgical outcomes. They need much more resection than only focal pathology. This is something. These are the very subtle focal this transmantle sign. I mean, majority of the time they are missed. So as a neurosurgeon looking at a focal cortical dysplasia story, we should have a habit, or even as an imaging specialist, we should have a habit of scrolling all the scans slowly in all the slices in sag, coronal, and axial, because there are few transmantle which are only seen in axial, there are few transmantle which are only seen in sag, and there are few transmantle which are only seen in coronal. So we should have a habit of looking all the three planes very slowly, scrolling it. Another chapter is infantile pathologies. So if you look at this scan, there is only a hypermyelination seen here in the occipital region. Apart from that, there is no other finding. But this hypermyelination is a very much indicative of a focal cortical dysplasia. It was missed and later on found, and she's operated now seizure free. But this finding is very classically missed because infantile imaging is very tricky, and it's very difficult for it's not a routinely done by many of the radiologists, even the neuroradiologists. Similar is this infantile. So very subtle hyper, blackish uh, intensity on T2 weighted scans here. So in infantile imaging, T2 axial is the very good scan and less than 6 months. Flare is useless. And after 6 months to 18 months, it's very difficult to pick up such abnormalities. So generally, infantile scans should be preferably done 6 months. And if they're not done, then it's very difficult to pick up these subtle abnormalities. So this is only a hypermyelination here, and which we picked up, and it's a focal cortical dysplasia basically, type 2A. Another substrate in such focal cortical dysplasia is a double cortex, very subtle double cortex. See, most of the common double cortex, it will be picked up by many, but subtle is something, if you can match this subtle lining here, which is seen in the posterior aspect. So she has a posterior gradient in this heterotopia, basically, subtle subcortical heterotopias. Again, the No, the same. See, if you look at the coronal, you will see the subtle focal cortical dysplasia. So sorry, subtle band heterotopia, subcortical heterotopias. This is one thing which is commonly missed and very commonly found in our particular Indian subcontinent is parotoccipital gliosis. So if you look at this, the only difference that you've seen is the white matter here. The age of this patient is 20 year. That's why this white matter change is very significant, because look at the sharp, I mean the blackish white matter in flare compared to whitish hyperintense white matter. And this patient is a parotoccipital gliosis. There is a strong clinical phenotype, but this findings was missed and he was labeled as something else. But this is a very classical finding. You will, I mean, if you don't look for this finding, it's likely to be missed. Very common syndrome which is missed is bilateral perisylvian polymicrogyria. Because these are very subtle sometimes, so that's why these are missed. But in a clinical phenotype of bilateral temporal discharges, one should be looking at bilateral posterior polymicrogyria. This is very common, generally not missed. This is a periventricular nodular heterotopia, generally not missed by radiologist. But these are, if very small, generally garland occipital type of variety will be missed. Infantile imaging again, very subtle white matter change here. Generally missed by missed if you are not looking at it. So this is a large cortical dysplasia. If you look at here, so only difference you can see is probably the crisp bright white matter here and a dull white matter here, which is matching the frequency of gray. So these are very subtle imaging shades that changes, but that takes you to the diagnosis of MRI. So cardinals of dysplasia detection, index of suspicion. So before confirming that what we are looking at is actually a dysplasia story, looking at MRI generally leads you to a confusion and negative results. Imaging quality is must, improving the coil strength, 3 Tesla, and the sequences is, I mean, very imperative for the diagnosis of focal cortical dysplasia. Electrophysiological data is very important, because without that, if you start looking at MRI, most of the time you will find something discordant, which will eventually lead you to the false outcomes and conviction. So this conviction is actually comes from very high index of suspicion, a good electrophysical physiological data, and imaging quality. So once you achieve these three, this moving to fourth is really easy. With this, I thank you very much for this opportunity and open for questions. This is our department, which is now 20 people are working in the department. Thank you very much.
Now it is over to Dr. Nalabhaskar Rao for his talk.
Can you see my screen?
Yes, sir. Yes, sir. Make it a slideshow.
I'm just trying to do that. Why it's not happening here?
You should do a slideshow. It is in the lower line.
Is it
Yes.
slideshow now?
Yes, yes.
Good. So I'm sure young neurosurgeons who are aspiring to be epilepsy surgeons must have realized that before embarking on epilepsy surgery, especially for difficult case, one should know about epilepsy about semiology, about EEG, and should have a deep interest in neuroimaging like Nilesh, then you will be able to establish a program successfully. Let me thank the leadership of NSI and the webinar committee once again for giving me this opportunity to share my experience, and also greetings from the Indian Epilepsy Society. So in epilepsy surgery, the best outcomes are achieved with hippocampal sclerosis as the substrate, because the lesion as well as the focus is very well confined in the mesotemporal area. Malformations of cortical development, in contrast, need very innovative and complex pre-surgical evaluations as well as surgical management, because the unlike hippocampal sclerosis, the malformation can be anywhere in the brain. Malformations can be large, malformations can be subtle, or even MRI can be normal, apparently normal. And another issue is the focus, electrophysiological focus. There can be a concordant lesion and focus, or there can be a discordance. And it will be very challenging if you encounter a person with progressed epilepsy involving the eloquent areas, because the what you see as a malformation may have some function also. So if you remove it completely, there may be cure, but there will be functional deficit. And to preserve, if surgery is conservative, then it may not cure epilepsy. So lot of complexities are involved in managing these people. Fortunately, in India, the national institutions have taken a lead in the beginning, and then doing excellent work. But now, not only the public sector, even the private sector institutions are embarking on epilepsy surgery in a large scale. Now we have more than 60 epilepsy surgery centers, and then I'm very proud of my young neurology and neurosurgery colleagues who are working for these people with difficult to control epilepsy, very complex substrates with minimum facilities, including not many places have got stereo EEG or invasive evaluation, but still they are able to take care of these complex substrates. This is a paper by my teacher, Professor Ramamurthy, that which says that you have to work with whatever technology available at your disposal, but still we'll be able to should be able to deliver good outcomes. So everything available in the mainstream neurosurgery is being used for the epilepsy surgery. So one of the most important things is to understand the clinical, electrical, and imaging concordance, and find the lesion and find the focus, and know whether they are discrete or non-discrete, concordant or non-concordant, and the epileptogenicity is intrinsic or extrinsic, and use not only during the surgery, during the craniotomy, you can look at the brain and try to identify the substrate. And at times, senior surgeons, I know, even sometimes I also just gently touch the brain and then see the consistency, whether it is firm or just like adjacent to normal brain. And everything in mainstream neurosurgery is used for epilepsy. Like you can do awake craniotomy, you can use navigation, you can do corticography, you can use intraoperative monitoring, you can use intraoperative imaging, ultrasound and CT, and then use different techniques like subpile technique to completely for a gross total resection of the malformation. You can do inside out a technique when it's in the eloquent area. Just enter the lesion and then keep removing the lesion, and then the moment you reach lesion to normal brain interface, stop. Or if it is a non-eloquent area, you can do outside in resection for a gross total. Again, circumferential resection and block resection, gross total resection, and at times I know some centers use even uh, um, fresh intraoperative histopathology to see the margins of the suspected dysplastic area, whether it's completely resected or not. I think young neurosurgeons must learn craniocerebral topography. You should have a navigation inside your head. Having a machine outside is a compliment, but inside your head, you should know for example, if there's a depth of sulcus dysplasia, you should have a three-dimensional image in your head. Where is the lesion? Is it right side, left side, anterior, posterior, temporal, frontal? And what is the relation with coronal suture? What is the relation with sagittal suture? All things you should have an idea before using navigation or any other intraoperative gadgets to localize these areas. I'll just share my learning curve. For example, nearly 30 years ago, this is one of the patients I operated at Sri Chitra. You see the arrow is misplaced. So you see here there's a prominent sulcus is there, and it's very close to the coronal suture. Prominent sulcus very close to the coronal suture. So I made craniotomy around the coronal suture, and then you see this prominent sulcus is exposed. So and then the lesion was resected based on this craniocerebral topography. Same way here, you see here this is a transmantle dysplasia. You know, from here cortex white matter junction all the way up to the ventricle, the abnormal neurons are in the white matter. So even the resection followed the same topography from the bottom of sulcus up to the ventricle, leading to gross total resection. Of course, you should be smart enough to identify which case is easy and which case is difficult, and which case can be done with non-invasive evaluation, which case needs invasive evaluation. This is a non-dominant orbitofrontal cortex dysplasia. You see gross total resection of the dysplasia was done. Again, this is a non-dominant temporal lobe. You can see this is there is a sort of clear demarcation between this malformation and then adjacent normal brain. This is a mix of polymicrogyria and nodular heterotopia. Again, gross total resection was done. You can see the substrate and then the extent of resection. And I'll just show you two cases. See, this girl started having focal seizures very early in childhood, very frequent seizures, and then she developed focal status with the epileptic encephalopathy. And then what we found is that there is a lesion malformation on the left hemisphere involving the inferior frontal gyrus, very adjacent, partially involving the Broca's area, and then because of epileptic encephalopathy, because of risk of sudden unexplained death in epilepsy, and also because of socioeconomic reasons, we went ahead with surgery without invasive evaluation. Also, she's 4 year old when operated. Although we know that if surgery is done early childhood, there's a compensatory language development in even in the opposite hemisphere to save life, and the resection was done. This is the PET which showed the decreased metabolism corresponding to the anatomical lesion. You see, this is the subpial en bloc gross total resection. This is the pial coagulation. You see, this is the left side. This is the Cillian fissure, and this is the superior temporal gyrus. This is the inferior frontal gyrus. This is the anatomical Broca's area, and after the pile coagulation and cutting, it's like a en bloc resection. You see, this is all abnormal dysplastic cortex. You can see this is surrounding white matter, and you see this. It's a subpile resection, like you can see in the deep Sylvian fissure, and this whole thing was resected together as uh, en bloc specimen. If you use CUSA and fragment the tissue, then it is possible that bits and pieces may remain, leading to incomplete control of heresies. This is the resection cavity. You can see the lesion pre-op and then extent of resection post-operatively. This again is another 1.5-year-old child involving left upper limb focal motor seizures. You see the focal seizures involving the left upper limb. Yeah, you see the focal seizures, and she also having frequent clustering of these episodes, and she has got epileptiform discharges in the right frontal area towards the central sulcus, and this is what we found on the imaging. You see, this is this is the lesion. This it is involving the motor cortex and going all the way up to the up to the ventricle. You see, again there is another small area of hyperintensity was noticed in the occipital area. So when we did craniotomy, the brain is absolutely normal. You see, this is the lesion which is involving the central sulcus area, Rolandic with Rolandic focal motor seizures, and brain appearing absolutely normal. So how to manage a case like this? So one is, of course, the palpation showed that this area it's quite firm compared to rest of the area. And then I went back to patients the cortical venous anatomy, and then this lesion is very close to very close to this. There is a vein which is parallel to the superior sagittal sinus, and then this lesion is just next to that. So this is that parallel vein, and so this is the area of abnormality. And once we could able to locate with venous anatomy and then with palpation, rest of the surgery became easy. It was dissected from all around. I did not even dissect up to the all the way up to the ventricle, but see, this is after dissection. This is just a removal. Order the video. You see, all the way up to the ventricle. See, the whole lesion extending up to the ventricle has come out as an en bloc specimen. Without because I was concerned about injuring the corticospinal tracts if I reach up to the periventricular area. I did not dissect in that area, but I think probably it's a 1 year 3-month-old child. Myelination is not completed, so the entire lesion, even without separation with instruments, it came as an block specimen. This is the type 2 dysplasia, and as expected, she developed deficit, and then over a period of a few months made substantial recovery. So all these interventions have got risks are there, but the risks are more or less similar to adverse effects of anti-seizure medication, and of course we must take great care in minimizing these deficits. So when you want to expand and improve your epilepsy surgery program from hippocampal sclerosis to malformations, you should have a very good team and referring doctors, pediatricians, and physicians who come across these children first, and then you should expand your program from simple to complex, and then identify among the malformations what are easy, what are difficult cases, and the progress is from non-invasive to invasive evaluation. And then in every case, you should identify not only the lesion, but the anatomical focus also. And then every effort has to be made to minimize the deficits. You must realize that there are some difficult cases, MRI negative, eloquent cortex, and type 1 dysplasia, and those who require stereo easy evaluation. And it's always debate when we operate on eloquent cortex whether priority is Caesar cure or the deficit and the deal, what patient will get at the end of it. But there is a very interesting paper from China which came recently saying that people with malformations, their deficits in 1/3 of their series, the deficits, preoperative deficits improved following resection of the eloquent area lesions, suggesting that these lesions they may not have function in a majority. So especially if it is bright, hyperintense T2 glial component, no function, you can easily resect them without causing any deficit. And also we should have a strategy, especially in India, when there is a double dual pathology. For example, if there is a dysplasia with hippocampal sclerosis or dysplasia with DNET, or even if they're far apart, we should still attempt to resect both to avoid invasive evaluation. And please use extensive prehabilitation and rehabilitation. And please share your experience with the referring team and your junior colleagues for training and research purpose. And please preserve this tissue. It's gold mine for research. And I'm very eagerly waiting for Dr. Walsh to share not only about deep insight into basic science of malformations, but also how we can preserve the precious tissue and then use it for scientific and research purposes, and also how we can collaborate among institutions in India and also international collaborations like his center at Boston. On that note, I'll stop here and then thank you very much for your attention. So
We'll
over
move to
to,
Dr. Walsh talk now.
yeah.
Should I begin?
Yeah, please share your presentation. Yeah, we can see your screen.
That looks okay.
Yes, yes, yes. Good to go.
All right. Well, thank you very much, Dr. Rao, and all of the speakers today. Can you hear me okay?
Yes, yes.
Great.
Yes.
So I'll try not to run over time. I know the time is getting short. Malformations of the cerebral cortex are incredibly diverse. And in the limited time I have today, I don't have time to talk about most of them. And so I'll be focusing my attention on surgically treatable cortical malformations, which are generally focal and asymmetrical. So in the last few years, we've known that every time a cell divides, it accumulates mutations that are not present in the germline. And these mutations can occur very early and be present throughout the body, or they can occur much later and be in just one hemisphere or even in a lobe of the hemisphere. And so in my time today, I'll be talking about two clonal disorders associated with intractable epilepsy and which frequently come to surgical treatment. First, I'll talk about activating mTOR pathway mutations in intractable pediatric focal epilepsy with focal cortical dysplasia. And then I'll talk about actually the more common type of epilepsy surgery, which is that done for hippocampal sclerosis, as several people have already mentioned, and what we've learned from studying the tissue of those temporal lobe resections. So our own work on this started more than 10 years ago by studying hemimegalencephaly. This is a case of a young boy who had intractable seizures starting at birth, along with left-sided weakness because of right-sided hemimegalencephaly. this was more than 20 years ago. He underwent a fairly extreme hemispherectomy, but that allowed us to study the tissue and gave a very good seizure outcome. He was seizure-free for more than 9 years, although he now has mild epilepsy that's well treated, and he learned to walk. He has fluent speech. He reads at grade level. He's now in his teenage years. And so Ann Paduri, who was in my lab at that time, wanted to understand what's the genetic basis of these asymmetrical malformations. And in the subsequent 10 or 15 years, this has now become canon in the epilepsy field, that both these large hemimegalencephaly lesions, as well as these smaller focal cortical dysplasias, represent clonal disorders that occur during development. They are stable lesions that tend not to grow, and they have activating mutations that invariably involve a single biochemical pathway, the mTOR pathway. They can be activating mutations in mTOR itself, or activating mutations in upstream regulators like PI3 kinase, or loss of both alleles of negative regulators like the tuberous sclerosis complex or DEPTC5. These are stable malformations, not cancerous, but there is overgrowth of mutant cells. And then the size of the lesion reflects then not the genes, but in fact, the timing of when the mutation occurs. You can see the exact same mutation in either lesion, but the larger lesions have the mutation in a larger fraction of cells, whereas the small lesions have the mutation in a strikingly small fraction of cells, typically 1% of the cells or less, despite the dramatic radiographic appearance of these focal cortical dysplasia type 2s. With the most sensitive sequencing technology, Jung-Ho Lee in Korea has shown that about 80% of these lesions can be shown to have mTOR mutations. And it's amazing you can get intractable epilepsy when you have the mutation in fewer than 1% of the cells. And this has stimulated the repurposing of mTOR inhibitors to treat cases that are not remediable by surgery. And that's been of some success, although it hasn't been a complete success. And there's important work from many different labs around the world. Stephanie Baulach in Paris, Bill Dobbins, Joe Gleason, and as I mentioned, Jung-Ho Lee in Korea. So how do these lesions work? How do you get from the genetic mutation to the intractable epilepsy? Well, histologically, we know these lesions typically have dystrophic neurons and balloon cells, two characteristic pathological hallmarks that can be recognized pathologically. We wanted to find out what are the cells that carry the mutation. And so for that, we analyzed about 20 focal cortical dysplasia resections, ranging in size from relatively small lesions to a couple of hemimegalencephaly lesions. And we analyzed them in a single cell basis to first understand what's the cellular composition of these lesions. Do they have abnormal cells because of the mutation, or and we found to our surprise that in fact you can separate different cell types in the brain based on their transcriptomic profiles. These different clouds in this UMAP plot represent layer 2-3 neurons, layer 5 neurons. These are the inhibitory neurons up here. You can see oligodendrocytes over in this cloud. And to our surprise, the cases show exactly the same patterns as the controls. You seem to see normal cell types in approximately the normal ratios, despite the intractable epilepsy. And this is work of several people, Sarah Bazzotto, Edward Strong, Maya Talukdar. This was published just last year in the Proceedings of the National Academy of Sciences. And so Edward developed a method where we could directly identify which of those cells actually carry the mutation. And so this is a summary of several different lesions, and you can see the different cell types carrying the mutations by the red dots over here in this genotyping plot. And you can see over here the different cell types that carry the mutation in the various lesions we analyzed. We find most commonly the mutations are in excitatory neurons, shown here in red, but they can also be in non-neuronal cells or inhibitory neurons. And again, surprisingly, the variant-carrying cells are typically well-differentiated neurons and glial cells in what seem to be normal lineage patterns, suggesting the mutation doesn't really change the cell fate very much. And that it's a mutation that occurs in the neuroglial lineage that gives rise to excitatory and inhibitory neurons, oligodendrocytes, and astrocytes. And the mutation is not present in other cell types like microglia or vascular cells that have a very different lineage. So in here you see, for example, a lot of the cells carrying the variant are layer 2-3 excitatory neurons. They're called intratelencephalic projecting excitatory neurons. These are the associative neurons in the upper cortical layers. So then now what happens to the profile of the cells that carry the lesion? So now we can focus specifically on that tiny fraction of cells, just a few percent, that actually carry the mutation and that have that activating mutation that's in the mTOR pathway. And so as you might expect, these neurons show cell type specific upregulation of mTOR signaling. Here we see layer 2-3 neurons, layer 5 neurons. They show this upregulation of mTOR signaling, although other cell types do not. And they also, mutant neurons also show cell type specific upregulation of many epileptic pathways, other channel genes and other things which tend to promote an epileptic state. So this makes sense to us that the activation of the mTOR pathway, which we can tell clinically is epileptic, it seems to do so by activating epileptic pathways as well as the mTOR biochemical pathway. But then, surprisingly perhaps, if you look at all of the cells in the lesion, including those that don't carry the mutation, in fact, the lesion as a whole shows downregulation of the mTOR pathway, shown here in the blue, and you see many different cell types all show downregulation of the mTOR pathway. And so what we now understand is that this resolves a paradox about focal cortical dysplasia lesions. As you heard about in the previous talks, FCDs are typically cold in PET scanning. They typically show downregulation of metabolism and are hypometabolic. And so what it appears to be, and yet that's despite the fact that this mTOR pathway regulates metabolism and the mutations are clearly upregulating the mTOR pathway. And the resolution of this paradox is that the small minority of mutant cells upregulate the mTOR pathway, but the vast majority of cells in the lesion are not mutant, and they actually show a perhaps compensatory downregulation of the mTOR pathway. So just to summarize this first part of the talk, it's now well established that focal cortical dysplasia type 2 and hemimeg are associated with activating variants in the mTOR pathway. Mutations are present in a tiny fraction of cells, and they activate mTOR in the cells that carry them. The mutant cells are relatively common in hemimegalencephaly, between 10 and 30% of the cells, but still that means that the majority of cells, even in these very impressive hemispheric lesions, are non-mutant. And then in FCD, the fraction of mutant cells can be quite small. Now, in the remaining talk, I'll tell you about work which is recently published and unpublished about what's going on in mesial temporal sclerosis. What causes that? So as you know, this is primarily characterized by neuronal loss and gliosis that can be visible by MRI and which is dramatic histologically, shown here in a pathological section where you see widespread loss of the brown staining neurons in the Ammonshorn field CA1 as well as CA2. And here you see the radiographic hallmark of mesial temporal sclerosis with a bright spot in the hippocampus. So mesial temporal epilepsy is a complex epilepsy. It has no known Mendelian forms. It has well-known non-genetic risk factors, and inherited genes play little or no role in its causation. And yet we've known since the time of Wilder-Penfield that temporal lobe removal can provide dramatic improvement in up to 3/4 of patients. So Sattar Kushgu, a former fellow in my lab, wanted to ask whether clonal somatic variants may also play an important role in this non-malformation associated mesial temporal lobe epilepsy. So our initial study design was to study a little over 100 cases with deep whole exome sequencing to a mean coverage about 500x. And in the interest of time, I'll go quickly over the technical details. And this was a collaboration with Dennis Spencer from Yale, such a pioneer in epilepsy surgery, Chris Kalle, who moved from Yale to MGH and enabled the collaboration. and then also Ann Pedori at Boston Children's Hospital, and Sam Berkovic and Ingrid Scheffer and their colleague Michael Hildebrand from Melbourne. And so we studied about 100 cases with a variety of pathologies, most of the mesial temporal sclerosis alone, so a couple of LEATs, a couple of focal cortical dysplasias. And actually, 500x whole exome sequencing of 104 cases actually revealed only 11 somatic mutations that were predicted to be deleterious. But remarkably, 10 of 11 of these were in the same biochemical pathway as one another, but in fact not in the mTOR pathway. They were instead in a different cancer pathway, the RAS-MAP kinase pathway, which is a familiar driver of so many different cancers. And again, they occurred in well-known cancer genes. In fact, they were the exact same alleles as many cancer oncogenes, the famous KRAS G12D, the famous BRAF V600E mutation. And all of these are predicted to activate the pathway. There were also mutations in negative regulators like NF1, which would also cause activation of the pathway. So more recently, Sattar wanted to find out what is the true burden of RAS-MAP kinase variants in mesial temporal lobe epilepsy, because here we only found these variants in fewer than 10% of the cases. And so for this, we did much deeper sequencing, greater than 1,000x, using a focused panel of genes, including genes in the RAS-MAP kinase pathway, the PI3 kinase mTOR pathway, but also some relatively common developmental encephalopathy genes, things like SCN1A, SCN2A, which also can cause intractable epilepsy. We asked whether they might also be present in the mosaic state. I'll skip the variant calling workflow. This now is a very large worldwide study. Unfortunately, not yet involving collaborators in India, but we hope we will. But involving Ingmar Blumke in Erlangen, again working with folks in Melbourne, a wonderful group at the Salpêtrière in Paris, and again our colleagues in Yale New Haven. You see our subjects by gender, and also by age at the time of sample collection, or we used post-mortem samples from patients that died with no known neurological diagnosis as controls, and they're actually harder to get than the surgical resections. And we focused specifically on mesial temporal lobe epilepsy with hippocampal sclerosis. And we avoided, for this study, we did not study temporal lobe epilepsy with other lesions for things like the low-grade epilepsy-associated tumors. And so we specifically were interested in what's going on in mesial temporal sclerosis. So overall, mesial temporal lobe epilepsy hippocampi have fewer somatic variants, but in fact, an enrichment of pathogenic somatic variants, that is, those that are likely to cause disease. And we saw very strong enrichment of mutations in genes in the RAS-MAP kinase pathway, enrichment of missense, nonsense, splicing, and truncating mutations. All of them were enriched in cases versus controls. Surprisingly, we saw relatively little or no enrichment of the PI3 kinase mTOR pathway. And so there's a tremendous specificity where RAS mutations are important in the temporal lobe, and the PI3 kinase mTOR mutations seem to dominate in the neocortex. And again, we saw also very little signal to suggest an involvement of these developmental epilepsy genes in the mosaic state in mesial temporal sclerosis. This again shows the various genes mutated, laid out, and we see all of these different genes which are all up and down the RAS-MAP kinase pathway. Overall, almost 40% of our mesial temporal lobe epilepsy cases had potentially pathogenic somatic variants, although these mutations are not uncommon in controls as well. About 20% of controls have them. So they are certainly enriched in epilepsy compared to controls, but they occasionally occur in patients that die without a neurological diagnosis. They're enriched at particularly mutational hotspots in genes. PTPN11 is the most commonly mutated gene, and we saw recurrence of specific missense changes that are known to activate the pathway. And then what we found was that, in fact, these RAS-MAP kinase pathways show evidence for positive clonal selection. So we see an overall enrichment of the pathway, but we can test for clonal selection using the same informatic tools that are used to define driver mutations in cancer. That is, those mutations that really drive the growth and progression of cancer. And there are tests called DNDS ratios, which actually identify those mutations that confer a proliferative and survival advantage, and that therefore are likely driving tumors. And we see these same effects for a wide variety of genes in the RAS pathway in mesial temporal sclerosis, where there is no tumor. But there nonetheless appears to be clonal selection within the neuroepithelial progenitors. So I told you we found mutations in almost 40% of cases, but our sensitivity analysis suggests that the burden could be more than double what we actually see. And so it could be that these mutations occur in the majority of cases if we had the sufficient sensitivity to detect them. So we divided our cases based on when they presented with epilepsy and then when they had surgery. And so we had cases that presented early and had surgery early. We had cases that presented early and had surgery late. And then we had cases that presented late and had surgery late. And what we find is that the RAS pathway variants correlate with late age of seizure onset and late age of epilepsy surgery. These are the conventional late onset adult surgical cases. And there are the ones that are specifically enriched for the RAS-RAF MAP kinase pathway. For the early onset cases, where there's early surgery, there we see some signal for the PI3 kinase mTOR pathway, although we also see RAS-RAF MAP kinase mutations in that. And again, if you look at the age of seizure onset for the different cases that have RAS variants or PI3 kinase variants or the developmental epilepsy variants, you see that consistently the RAS ones are associated with later age of seizure onset, as shown by this red line, and later age of epilepsy surgery. So it's a particular type of patient that's most likely to have an activating RAS mutation in their temporal lobe. So now, what are the origins of these variants? How do they come about? So we can learn a little bit about that by comparing the variant allele frequency in the dentate in the hippocampus to that in the neighboring temporal lobe, which is often, as you know, removed because of the fact that because you have to remove that to get at the medial temporal lobe. And what we find is that these activating RAS MAP kinase variants are almost always exclusive to the hippocampus and absent in the lateral temporal lobe neocortex. Now, if we take the resected hippocampal tissue and we sort different cell types, specifically neurons, oligodendrocytes, and astrocytes, we find that the mutation is typically present in all of these cell types derived from the neural cell line, but again, it's absent in microglia or in vascular cells. And so this suggests that most of these variants occur in neuronal stem cells that are formed after the separation of the hippocampus from the neocortex. So that would occur either during late gestation, or in fact, some of these variants might occur postnatally because, as many of you may know, the dentate gyrus of the hippocampus continues to form neurons for several years postnatally in humans, potentially throughout life. Now, these activating RAS-RAF MAP kinase variants are known to be inherently epileptic to neurons. There's a large body of basic studies that have shown that they change the pattern of firing, and if you put them into the brain of mice, they make those mice intensely epileptic. And so we think that these RAS-RAF MAP kinase variants are inherently epileptic, and their presence in neurons is what is driving the epilepsy. Now, we can also analyze what happens to the temporal lobe in the setting of hippocampal sclerosis. We see in temporal lobe epilepsy overall versus controls, we see a loss of particular cell types, the MGE-derived interneurons, the pyramidal cells, and VIP neurons. But in hippocampal sclerosis, we see a much more dramatic loss of neurons, as you would expect, because there's such extreme neuronal loss, as well as an increase in certain inflammatory cells. And finally, we see upregulation of a variety of developmental pathways, as well as the RAS-RAF MAP kinase pathway in these temporal lobe lesions. And so here's how we think mesial temporal sclerosis may work in the hippocampus. And the important thing is that they're subject to postnatal effects. So the human hippocampus shows neurogenesis after birth, at least for a few years. And this has the potential then to allow life events to modulate the risk of epilepsy. For example, this process of hippocampal neurogenesis is known in animal models to be regulated by physical activity, by seizures, by head trauma, and many other things, some of which are known risk factors for temporal lobe epilepsy. And so here, after a seizure, there's a wave of neurogenesis in the dentate gyrus. After head trauma, there's also a wave of neurogenesis in the dentate gyrus. And we know that, in fact, the mutations, these activating pathway mutations, they actually provide cells with a proliferative and survival advantage, so that if you just take cells in culture and mix mutant and non-mutant cells over several passages, the mutant cells tend to take over. And so we think that many of us may be born with a small clone of activating RAS mutation cells, and that these are inherently epileptic, but that this might be a latent risk that might be present in some normal people, perhaps 20% or so. But then risk factors stimulate proliferation in the dentate gyrus broadly. That would allow these mutant cells to become more frequent, to undergo positive clonal selection so that the mutant clone becomes relatively larger, and the higher fraction of RAS mutant cells would then increase epilepsy risk. So this model can explain several things. First of all, the predilection of adult epilepsy for the temporal lobe in the first place. So as I think you know, clinically, focal epilepsy in adults almost always happens in the temporal lobe and is rarely neocortical in origin. And then there's this other phenomenon whereby seizures beget seizures. So that a patient may have his first seizure at age 16, but then the second seizure may occur 6 months later. The third seizure might be 6 weeks later, and the next seizure might be 6 days later. And the seizure may become increasingly intractable, as though there is something about epilepsy which is itself inherently epileptic. So with that, I'll just conclude and thank you for your attention. Again, this work was driven by Satar Kushku, who now is an independent investigator at the Brigham, and Yilan Wang, a bioinformatician in Alice Lee's lab, and more recently Mingyun Bei, who's a bioinformatician in August Wang's lab. If you're interested in hearing more about this study, this is a link to it's a preprint available on bioRxiv, and feel free to contact us. We'd love to collaborate to analyze surgical tissue, both from focal epilepsy in children as well as hippocampal sclerosis in adults. Thanks very much for your attention.
I think Dr. Matthew and Dr. George can make some comments. And Dr. Anita, did Anita join?
I don't think.
Yeah. I think she's in the meeting.
Okay, we welcome Dr. George for his opinion.
Yeah.
Thank you very much. I hope you can hear me very clearly, sir.
Yes.
Yes.
Yes. I think it was a very fascinating presentation from all the speakers, with the icing on the cake in the end by Professor Walsh. I think as epilepsy surgeons, I'm sure Nilesh and Bhaskar Rao sir will also agree with me that some of our most memorable cases are also FCDs, and also the most frustrating failures are also focal cortical dysplasias. So these are, very, very deceptive lesions. And then, I'm actually incidentally now sitting in a hearing an oration at the conference of the international meet on magnetic resonance imaging, where there is a very nice oration on 7 Tesla MRI going on. So the question which probably I should start off with posing to Dr. Nilesh and to Bhaskar Rao sir is that in the future, in the era of 7 Tesla MRI, would we have no entity called MR negative epilepsy? So can we just start off with this question perhaps?
Probably Nilesh will give a more elaborate answer, but not only 7 Tesla, even subsequent technical advancements also miss some cases. I mean, it can be absolutely normal, and MR negative histology positive cases are there. And now there are reports of MR negative and histology negative cases also. So it is virtually impossible to detect those MR histology negative cases with any sort of imaging. Of course, future will have great advances. I think Nilesh can talk about post-processing. And of course, post-processing, there is a lesion which conventional imaging missed, and then they'll be able to spend time and then try to identify. Nilesh, over to you for your comments. Nilesh, you're muted. Anyway, I think Nilesh will come back.
So,
What
sir,
is
yeah,
your
I'll keep the discussion going. One of the important take-home messages is that when we look at just the MRI, as neurosurgeons, we are forced always to be structurally guided in our surgical resections. So when we look at focal cortical dysplasia MRIs, we realize that it's a very, very large spectrum. Sometimes some of the lesions can be just blink and miss lesions, where if you don't look at from a trained eye perspective, you may even miss the lesion completely. And to the extent that you may have the entire hemisphere, involved in large hemimegalencephalus, and the spectrum also includes, heterotopia. You have tubers, you have even, hematomas. So the spectrum is really, really large. So when the anesthetists often ask us a question, will it bleed? So we really don't know, because sometimes the approach, because of this large spectrum, it's an umbrella term. And when we find these T2 hyperintense area, we have to see them in a holistic perspective, not just the image abnormality. So we have to look into the fascinating spectrum of the semiology that Professor Gagandeep told us. So there's no point in having a T2 hyperintensity in the occipital lobe and your seizure semiology being of a frontal semiology. So putting it all in perspective is the message to the young neurosurgeons. So they say that, when you have a hammer in your hand, everything looks like a nail. So be very balanced in your perspective, in your holistic imaging, evaluation of the clinical and electroclinical semiology. And when we in our patient management conferences actually look at MRIs of focal cortical dysplasia, we do two things. First is that we have two very experienced radiologists who look at it. So we first show it to a radiologist who is actually blinded to the semiology. So we ask him to pick up anything abnormal. So he looks at it with absolutely no idea about the semiology. He looks at it just like an image, and sometimes the image is negative. Then we get another radiologist to look at it with electroclinical semiology. So he knows where is the focal abnormality in the EEG, in the semiology, and he knows where to look. Like when you know where to look, you're likely to find MR positivity. So it is like when Bunty Chor was asked, why do you only rob some houses? He says that because kuch gharon mein paisa hai. In other words, there are some houses which are rich. So that's the same the principle here. So knowing where to look sometimes makes you a little more smarter and wiser. And one of the other imaging modalities which we find very useful now is the poor man's PET scan, which is known as the arterial spin labeling, ASL sequence in MRI, which almost has completely replaced the need for a PET in our experience. And it's very, very, whenever you have PET positivity, you also have arterial spin labeling positivity. So almost I think 80 to 90% of imaging in focal cortical dysplasia, you can obviate the need for a PET with a ASL. And another important imaging modality which has been found very useful is an intraop ultrasound, where there is very, very clear ultrasonological signal changes which can be easily picked up with intraoperative ultrasound, and it has almost transformed the intraop identification of focal cortical dysplasias, because most of these lesions are imaging positive but morphologically negative on the operating table. So intraop ultrasound has really made a lot of difference in imaging of focal cortical dysplasias. And a very important point that we have to always remember is that in the developing brain MRI, the focal cortical dysplasia you see in a 1-year-old child may have a little bit of a different morphology when the child grows up to 5 years of age. So often when the tracks are not myelinated, many things can sometimes look as focal cortical dysplasia. So developing an experience with a skilled epileptology team, especially a radiological team, in interpreting neonatal and MRIs in the first year of life are very, very important in the imaging of focal cortical dysplasia. And these are the main points that I wanted to highlight. And one of the most important dilemmas which comes up, especially seeing the case which Professor Gagandeep Singh presented, is you have children with large focal cortical malformations like hemimegalencephaly. Some of them are extremely low birth weight, just about 3 to 4 kilos, and you have the dilemma of whether you want to wait further or till they gain some weight to stand to accommodate or to survive a major blood loss of surgery, or you want to intervene early. So that is always a very difficult question and difficult scenario, and I'm sure Professor Malla Bhaskar Rao and the other stalwarts in this field can throw light on that aspect as well. Thank you very much.
Thank you for
I
your
just,
comment. Yeah, Dr. Matthew, please.
yes, I had just a comment to make. I must say this cortical dysplasia is the most humbling of epileptogenic lesions. The Even the best surgeon can miss huge lesions just because the imaging is so vague. I fully agree with what George said that ultrasound is becoming a very important tool. Cortical dysplasia, all experienced surgeons will know, has a different feel. During surgery, it has a different feel, and hence also has different tissue elastic properties. This will make it a particularly good candidate to identify with an ultrasound. And the experience of the surgeon in tracking out the entire lesion seems to be quite important, and aided with ultrasound, probably you can get a wider excision. I just had a query to Dr. Walsh. Uh, uh, Dr. Walsh, do you think super selective resections within the mesial temporal region is likely to become an option in future?
Well, I'm not a surgeon, so I don't know that I can't really advise on various surgical practices. At the moment, that would require, I think, that we learn a bit more about the genetic distribution of the mutant cells through the hippocampus. They're very likely to be enriched in the dentate gyrus region. I think that what we see from our data, one of the reasons perhaps why temporal lobe removal is so effective is because in most of the cases we studied, it removes all of the mutant cells, right? The cells carrying the mutation are present in the hippocampus, but absent in the lateral neocortex. I think that's in contrast to the focal cortical dysplasia, where the clonal structure of the neocortex is very different, and there are likely to be mutant cells. In my own view, we haven't been able to test this experimentally, but my own view, it's likely there are mutant neurons that extend far beyond the boundaries of the lesion that cannot be seen radiographically, because the radiographic, changes, as you point out, are often subtle. And so I'd like to think, we've done a little bit of experimentation in the case of focal cortical dysplasia using removing DNA from the implanted stereoelectrodes to recover DNA from the depth electrodes and use them to try to genetically map the lesion. So I could imagine that something like that might be possible as we develop depth electrodes that might be better able to allow us also to recover a little bit of DNA from the lesion. We may be able to map the genetics of the lesion, be that in the temporal lobe or perhaps more usefully and importantly in the neocortex.
Yeah, Dr. Matthew, can I ask him a related question? Actually, when you said gene mutations are identified only in less than 1% of the cells. So we know that high frequency oscillations are one of the earliest biomarkers. High frequency oscillations electrophysiologically. So these mutant cells must be causing those high frequency oscillations. This is a hypothesis. So in future, it is possible to create thermal lesions, either laser ablation or radio frequency ablation. I think resective surgery will come down significantly. Yeah. What is your?
Well, I think that the circuits involved are very complex. Given that focal cortical dysplasia will carry a mutation in only about 1% or 5% of the cells, presumably that means that the mutant cells must recruit genetically wild type cells into abnormal circuits, that can reverberate and that can amplify themselves. And the same might be true in the hippocampus as well. It's also possible that the presence of an extratemporal lesion or the presence of epilepsy arising of extratemporal. I know we're all familiar with the fact that you can sometimes see hippocampal sclerosis in a patient that has a different focus as well, that a hippocampal focus can develop secondarily, and that might represent an effect of the epilepsy essentially generating a second focus in the temporal lobe.
If I can just make one comment regarding this ultrasound, there was a lot of discussion. I think intraoperative ultrasound is very good, but one development which is in the beginning is functional ultrasound. Just like we got functional MRI, in functional MRI data is obtained prior to surgery, preoperatively, and we are not able to use the data during surgery, functional MRI bold signal, whereas functional ultrasound after craniotomy, after dura is opened, we from the cortex, using functional ultrasound, we can elicit actually the electrographic spiking areas, not just seeing the morphological area, even electrophysiological, which areas are spiking. It is possible by bold signal of these spiking neurons. I think that is likely to come to clinical practice in the next few years, and that will be very friendly, very user friendly to the surgeons. So we know, like volume, we know by lesion. Similarly, focus volume also can be identified with functional ultrasound in the future. There are some papers are already published in this area. Would you like to make any comment regarding that, or it's out of your area, Dr. Walsh? Is it fMRI? F ultrasound is probably, you may not be dealing with that. That's fine. That's fine. So one question, yeah, regarding this collaboration. All of us have got substantial amount of surgical volume and then specimens. But as per the Government of India regulations, ICMR guidelines, biological tissue samples cannot be exported out of India. So is there anything, we have to find how we can collaborate. Those who are interested can, I mean, you have shared your contact details. Those who are interested can directly contact Professor Walsh and then collaborate. And then we find you would like to expand that area a little bit, how we can collaborate, how you collaborated with international institutions from US.
Well, so generally we've done that by receiving tissue. So that does create a hurdle for collaboration because the analysis of the tissue, requires some sort of specialized sequencing methods and so forth. But I guess the logical way to do it would be to identify a wet lab, genetics lab in India that might be able to coordinate efforts where the tissue would not have to leave the country of India, or whether there's any way we could get a waiver from that prohibition on exchanging tissue for the purpose of scientific collaboration.
Yeah, sure. I think Dr. George and Dr. Matthew, I think Dr. Anita is not there. She's in a meeting probably. Any further comments? Dr. George, you wanted to clarify regarding something. Can you please repeat if you? I think. What about is?
Yes, just another quick point on just that sometimes FCDs are just part of a bigger spectrum of multiple focal cortical malformations. So we need to remember that sometimes when we have many heterotopias or many FCDs in a single patient, we need to find out which of them is the dominant epileptogenic lesion. So sometimes with invasive EEG and other forms of your better identification of the dominant lesion. Sometimes that is very essential. And the second thing we need to remember is that type 3 dysplasias, which are associated with other lesions like hippocampal sclerosis per se, vascular malformations, long-term epilepsy associated tumors, and gliosis. So they might be part of a bigger spectrum. So FCD is just an innocent or rather one of the contributory bystanders in this large spectrum of disease. Thank you.
Dr. Matthew, are there any questions in the chat? I think there are some. I can see 3 questions are there.
Yes, sir.
Any other questions are there from any other participants?
I think we are almost coming to our closing time. So there is no other questions. We'll close the session.
I think there is. Sorry, Kodeshwar, sorry to interrupt. There's a question on whether the NSI could organize an epilepsy functional neurosurgery workshop. So may I just take a minute to answer that? So the
Yes, please.
NSI also has a subsidiary in the sense we have a subspecialty society, which is the Indian Epilepsy Society, of which Professor Bhaskar Rao is the president. We also have the Indian Society of Functional Neurosurgery. So both of these societies have been very active in organizing workshops for epilepsy surgeons. So I understand that surgeons are more interested in technique rather than the semiology and the electroclinical aspect of epilepsy surgery. But both of these are well covered in the subspecialty meetings. And I think this year also there are subspecialty conferences where workshops are on the agenda. So I'm sure, Dr. Raghavendra, you'll find an opportunity as the months of the year go by. Thank you.
Dr. Gagan, Dr. Nilesh, any comments from you? Closing remarks?
No, I just must say that I thoroughly enjoyed all the lectures subsequent to my own. I couldn't enjoy my lecture. You never get to know what you're speaking, but all the subsequent lectures are absolutely fascinating, and the spectrum of cases, and then eventually ending with an understanding of the molecular basis of many of these focal cortical dysplasias. So I think it's been a very fascinating thing for me, and compliment all the speakers, all the subsequent speakers for a fantastic talk, right?
Yeah, thank you. The gap between basic and clinical sciences seems to be far and wide in India. I wish and I hope. I mean, people like you are in very influential positions regarding inter-institutional collaboration and international collaboration. Maybe you can influence the government and then some guidelines, some help, some tips for younger people to follow. So maybe you can share your ideas at a later point. Also, within India, also we should. I mean, wherever there's an opportunity, we should see how we
I
can.
think it's extremely important, and I know that Dr. Bhaskar, you have taken some initiative in that area, and you are collaborating with, for instance, the Indian Institute of Science. So I think yes, but what I would like to refute the point is that I'm not influential. I don't think I'm influential, right? But collectively we can be very influential. So I think that's extremely important.
So, any comments from Dr. Raghavendra, Dr. Our coordinator, and then finally last comment by Dr. Kodeshwaran.
Yes, sir, it was a wonderful joint meeting of ILE and NSI. So we had great talks about epilepsy surgery and also the basic science of seizure semiology and in imaging. The Nilesh talk was wonderful because I thoroughly enjoyed all the talks, especially Nilesh, because he was showing the real fact of imaging of epilepsy surgery, and all young neurosurgeons might have had a good idea about how we have to work out for epilepsy surgery, and hope we in future we'll develop a lot of epilepsy surgeons in our country. This is a motivational program for all young neurosurgeons. I hope this will continue. As Dr. Raghavendra said, I'll represent to BOE, Dr. Dwaraknath, about this workshop in NSI, coming NSI Con or progressive meetings of NSI to create some workshop related to epilepsy surgery.
Yeah, just one last comment is August 7 to 9, there is a epilepsy conference in Ludhiana. Professor Gagandeep is organizing, and in that there is a functional neurosurgery workshop is there, both anatomic cadaveric dissections and then a lot of electrophysiology. So those who are interested can register and then attend Econ 2026, Ludhiana, August 7 to 9. Thank you.
So I thank everyone for joining for the NSI joint webinar with the Indian Epilepsy Society. Once for all, we are celebrating our 75th year celebration. I hope we all meet in our upcoming NSI Con 2026 Ahmedabad. Thank you all.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you. So, right.